Hello, welcome in Rotterdam. Can you hear me?
Hear you, and it's wonderful to have you. I'm delighted. We have two concurrent cases. We start first with Erasmus, and I'm delighted to introduce Roberto Diletti and Jorgen Wilschka. So lovely to have you both here, and you have a great panel here as well with Holger Thiel, Nicholas Van Meegen, and David Hildick-Smith. So Roberto, to the case, please go ahead and give us your case.
Yes, today we have a very interesting case of a complex CTO PCI of ostial LAD, but I would like first to introduce my colleague and friend Jeroen Wilschut and my nice team. Maybe we can start immediately having a look of the case.
Okay. By the way, also a warm welcome to Rotterdam from me. Let's start with the case presentation. So what we're going to show you today, or share with you today, is I think a very interesting case. It concerns a CTO of a ostial LAD. The case concerns a female of 73 years old. She's been known with risk factors, hypertension and kidney disease. Also, she had had a CVA in 2014, and she was presented in the outpatient clinic with rapidly progressive angina, currently CCS class 3. Next slide, please. Additional surveys were taken, and echocardiography showed a slightly decreased LVEF of 49, close to 50%. She had clear hypokinesis of the apical area and no significant valve disease. Because of her complaints, and the echo, a SPECT was undertaken, and a reversible defect was seen anteriorly of 15%. And action was taken to do a coronary angio. Maybe we can see the slides of that. So what you can see here is, well, first of all, the CTO of the LAD, a calcified proximal LAD, which is closed at the ostium. Retrograde filling of the LAD through a lot of septal collaterals coming from the right. A coronary artery, which has no significant disease. Then also, strikingly, a subtotal lesion, calcified lesion of the proximal circumflex. And Roberto, I think you did the case. Maybe you can take it on from here onwards.
Yes. So this case was going to be discussed in our team because, as you can see, it's quite a complex case. But the patient, after this angio, got unstable again. So we had again a discussion with the referring hospital, and we decided to get the patient rid of complaints, stenting the C6 left main. So that was just last week stented the ostium of L6 and left main, and the stent was placed up to the ostium of the left main. First, the lesion was prepared with orbital atherectomy, so it was well prepared. And it was stented, it was successful, I was guided. So now the patient is back to finish the job, having a PCI of the CTO of the LAD. Maybe we can start having a look of the angio of today. We can show maybe the first angiogram of today, so you can see the stent there. What we saw immediately, the difference from last week, where there was a good apposition by IVUS, is that there was a sort of aneurysm just behind the stents. So last week by IVUS, it was well apposed up to the ostium. Now we see this. We don't know if the preparation with atherectomy might have facilitated this appearance, but this is what we have. As you have seen also with the other angio, we have good collateral from right. So we were thinking having also a retrograde approach. And we starting making an angio and checking this approach, as you can see here. When we engage the right, after the second angio, we saw that there was a dissection in the right, iatrogenic. So we made a dissection with our Amplatz left 1, 7 French, that is the guiding that we are using for the right. So we had to treat also the proximal right, which is treated now. And we are thinking what the best strategy is in this case. I would like also to hear what is your opinion, what will be your approach in this case?
Wow, difficult case, fascinating case, actually. So, David,
Yes.
let me go to you first. How would you approach something like this now? I mean, it seems to me that the orbital atherectomy probably caused some damage there. You were very careful to come to the ostium and probably didn't stent into the left main. There was probably some contained perforation or dissection, but obviously we see a little bit of an aneurysmal dilatation there. But we just talked so much about antegrade approach. Now let me hear what this team wants to do first. David.
Well, a couple of things, I think. I mean, the first thing is I would probably personally spend a little bit of time looking at this and trying to work out, perhaps with the benefit of IVUS, whether I think it's possible to get a safe and good result for this person with a PCI approach, now that there's this disruption of the left main. So that kind of concerns me, and I'd like to know a bit more about that. If we didn't have that, then I think what has happened so far was, in a sense, quite an elegant way of trying to ensure that the case became a little bit safer. Because, of course, one of the terrible dangers of doing an ostial LAD retrograde, which this is highly likely to be, is that you go retrograde with your subintimal plane track and close off the circumflex. So, you know, this is, in a sense, what they've done is a kind of stent reverse cart, but into a partial donor vessel. So I think they've made it safer. I am slightly concerned about the appearance of the left main and what the cause behind that is.
Holger, what would be your approach?
Yeah, difficult case, so interesting case. I'm looking forward on how they really want to manage it. So at least I would be prepared also to go for retrograde. So as a second step, try to do it antegradely, but for sure, I think in the end, it may be necessary to go retrograde. I've been looking for the septal collaterals. They look nice. So it should be possible.
Nicholas, any comments?
So basic.
I just wanted to just get from Nicholas.
Yeah, so this, of course, obviously is the team in Erasmus, so I know their mindset. But I would agree with David. I also would want to learn more from that ostium of that circ and the left main. So I would put a wire in the circumflex, do an IVUS, and then have a good assessment of that left main. And at the same time, I would also be interested in making a very good spider view in order to see whether there is a proximal cap in that ostium of the LAD that might help in the decision whether or not you want to at least attempt an antegrade approach.
Yeah, I mean, I think
Yes,
given
so
that it's been such a huge change just from the time of the last angio to now, I think it behooves you to see what's really going on in that left main. I don't know what you think. Go ahead. Sorry to interrupt you. Go ahead.
No, sure. No, it's basically also our thinking, because we already have the IVUS ready on the table. We had some feeling of the retrograde approach. We saw that despite having a lot of collaterals there, is very tortuous. So always our wire, we tried a bit, but it's quite challenging to go up with the wire, also retrograde. So what we want to do now is to have a little bit of a feeling of antegrade approach, and of course under IVUS guidance. So first we went in the left main with a wire. We went down in the circ, and then we wired the ostium of the LAD, and we brought there Corsair, as you can see here. And what we are thinking now that we are there, to advance a bit, to do a little bit of scratch and go down with a knuckle wire, and then perform an IVUS and be sure that we are good. And what we could do if we have a good dissection distally, to do an antegrade dissection reentry technique. That could be also an option, and quite a fast option.
Okay, well, show us what, why don't we proceed with your first step on what you're planning to do there.
So you see, we are already there with a cursor. Now the problem is the support. We have already a wire. We inserted already a filter for knuckling. So we are advancing the knuckle wire. Here it is. So let's see if it is knuckling good. You see the support is not great. I'll try to advance a bit the cursor. It seems advancing. Try to knuckle more. Let's get another projection to understand where is the knuckle. It seems in the vessel, in the LED.
Mm-hmm. Yeah.
Sorry, make this camera. So it seems in the direction of the LED. The problem here is a bit the support, because you have seen that the guiding is going back a bit.
So maybe a diagonal.
It can be that we are in a diagonal, as Jeroen is suggesting, because it's going down. We might need to redirect the knuckle, because this looks like a diagonal. So it seems we are dissecting a diagonal.
You are confident that your stent in the circumflex is outside of the left main. You already know that, so that's good. What about because you're struggling with the support? Would you go for a guide extension at this point, or say no? Let's keep on trying now.
No, guide extension is very good. I would like to have the wire a little bit deeper, because it's just at the beginning. I was actually thinking about a guide extension and then doing a reverse cut at the beginning, but we saw that the retrograde is not really very easy. But I see also now that it's going in the diagonal, probably not in the LED. So we need to rethink a bit. If this is not going easy.
The good thing, of course, about the knuckle is that it's so safe. I mean, we know even if it's going into a diagonal, you could opt to knuckle further. You would confirm its position, and then of course you would need another strategy to divert the knuckle to the LED. At least we know that it's such a safe exercise that we can rely on. We can trust the knuckle, as they say.
Yeah.
Yeah, perhaps.
Well, as
Joan,
you
can
guys decide what you're doing here, we'd like to go to the other lab. David, did you want to say something quickly?
Sure.
Just very quickly, I was just going to ask, have you gone through the stent or round it? Because if you've gone through it, are you going to...
Through the stent. Through the stent.
So did
it's
you,
through the stent.
They went through the stent, yes.
We will show you with IVUS also,
Sure.
but we are through the stent, not
My question was, did you dilate the stent strut so that you have some space for the corsair?
Not yet.
Okay.
Not yet.
Because
I would like
I
to have
always
a little
worry
bit of the
slightly
wire
about
down and then
trapping.
dilate it.
I always worry slightly about trapping
Well-
microcapillars if the stent isn't dilated at the start.
Yeah, sure.
If you don't
But I would like
mind,
to have the wire a
Roberto,
little
guys,
deeper.
we're gonna let you figure this out, and we're gonna let you pontificate about this, because I think it's an important one. We're gonna go to New York Presbyterian, and we'll be back to you in about 15 minutes. Let's go to New
Sure,
York.
thanks.
everybody.
Hi.
Nice to see everybody. Good. We got a good case
Good
for
to
you,
see
because
you.
time is limited. We'll try to get moving pretty quickly. Margaret needs no introduction. She's going to be doing this case. We have our CHIP fellow from Singapore, Deborah. We have Diane, Brian, Lourdes, Patty will be around too. So pretty awesome team for you, and a pretty interesting case too. So we'll go to the slides now, and we can show that. Okay, go ahead, Deborah.
Yeah, next. So we have this 56-year-old gentleman who presents with worsening angina. He has a previous bypass done in 2016, Lima to LAD and SPG to the CIRC and the RCA. So because of the worsening angina, he recently had an angiogram done in January. Echocardiography showed a normal EF. Next. So this is the RCA CTO showing proximal diffuse disease followed by the CTO segment after the small branch. Is ambiguous from here. And you can see the CIRC filling epicardial collaterals to the RCA. Next. Yeah. And you can also see from here the septals filling the RPDA, but it seems very small. Next. So we have the next piece. Yeah, we have this Lima shot, which shows the LAD providing epicardial collaterals as well to the RCA. Yeah. So next. Yeah. So here we have this gentleman with worsening angina in the background of bypass. I'll hand over to Margaret.
Okay, so we'll just discuss the previous angiogram, and then we'll show you the setup shot from today. So as Deborah said, when we reviewed the diagnostic images, our feeling was we had probably a blunt, slightly ambiguous proximal cap, what looked to be quite a long occlusion with diffuse disease and the distal vessel down at the bifurcation. And in terms of the retrograde access, we had epicardial collaterals from the circumflex and from the apical LAD via the Lima, both of which were non-usable for intervention. And we've got some septals. Now, the S1, as often in these cases, doesn't go to the PD. When you study the angiograms closely, it goes to a marginal branch, so that's not useful for us. There are then a series of 2 or 3 very small septals down to where the mid-LAD occlusion is, and they do go to the PDA, but they're probably CC01 septals, so we're uncertain whether they'll be crossable or not. So when we came into the case, we had a lot of discussion about it before it, as we always do, and our thinking was that we would take dual injections, and probably our strategy was going to be to start antegrade and think that we were going to probably end up subintimal because it's a long occlusion, and think about trying to re-enter just before the bifurcation, but into a disease segment, which often can be quite difficult. And then our backup plan was to come down those small septals and come retrograde and do a retrograde dissection re-entry. So that was our kind of plan up front. So I'll let Ajay show you the pictures from today that he took while I was upstairs giving the talk.
So if you can go to the fluoro setting, Sophie, and then we can show this. So our setup is biradial, and what we opted to do sometimes in these cases, and by the way, this is a pretty classic case, young patient, Lima open, all the other grafts are down, refractory angina. And Roxanne, I'm so glad you mentioned the guidelines in the conversation, because this, to me, is not a 2B indication. This is this patient with refractory angina, can't do what he wants to do, and his grafts are down. So the idea, though, is can you get this open, and how can you do it safely? And those are really important points. So we actually took a guide in the right, and that sits pretty well. We actually are not giving injections because you can see the green pressure tracing is damped. So we've actually disconnected the injector syringe from the manifold, and you can zoom in on the hands, you'll see how we do this. So nobody inadvertently injects into that. The other aspect of this is we took a Lima shot, and because we were radial, we have a much better picture from the Lima. We have a safety wire down the Lima itself, and there you can see we've disconnected from the manifold. But the shot from the Lima now, interestingly, fills much, much better than we saw before, because it's a more direct engagement of the Lima. So just the angiography alone, it's a great teaching point, is much, much better at this point than it is in the setup shots. And what you can see here is that there's 2 marginals that fill. The occlusion is shorter than it appears. You also see that there is, so there's the bifurcation filling in, then it fills back to there. So it's a relatively short occlusion that's less ambiguous or blunt than it was before. And you can even see the graft tenting site to where to go. So I think based upon this, we opted not to switch for an EBU guide, to keep this in as our distal injection and to start antegrade.
So this is a great example of how your dual injections, or in this case, a single injection, because we haven't taken any antegrade contrast at all. But how at the start of the case you have to be dynamic in your thinking, because the anatomy is completely different from what we thought it was from the original diagnostics. So now we've got a shorter occlusion. We've got a huge marginal just beyond the distal cap, which is where there's disease, which we need to preserve. Then, as Ajay says, as you come round in the distal right, we can see where the graft was attached. And then we don't see the PD from the antegrade, from the retrograde filling, but we get the sense of where the PD is coming off that PLV right at the very end there. So it's a nice example of how you have to have kind of some dynamic thinking about how you're going to approach the case. So our strategy now is going to be that we think it's worth a good go at antegrade wiring because the occlusion is shorter. And then if the antegrade wire ends up in the subintimal space, what we're going to then do is probably a more of a kind of parallel wire type technique with dual lumen microcatheter, because we need to preserve that big marginal branch at the distal cap, and the retrograde options aren't fantastic.
So what we'll do is Margaret will start working, and you guys can discuss the case and talk to us a little bit about how you would do it. I'm happy to answer.
What I love about this case, is I was sort of thinking, what are you guys thinking to even attempt this CTO? Because it just looked from the diagnostic approach that it would be really, really difficult and very ambiguous. And now with good angiography, I think you have a great case and a great example of Margaret's lecture. So I just think it's going to be great for us to kind of see it in action. Any comments, Holger? What do you think? Do you agree now? And David, you said, oh, this is going to be a retrograde approach, but you see, with better imaging now, we can go antegrade, and I fully agree. It looks like a short occlusion. I think Margaret's going to get this.
Yeah, so when I see when I saw this, I thought, though, this is a very challenging case, also because of if you want to go retrogradely, that you have to use epicardial collaterals. But now with better imaging, for me, it seems to be possible if they do it antegradely. And I'm looking forward if Margaret is really using the new techniques she has shown in her presentation. So hopefully this will be a good option to see how it works in clinical practice.
Yeah, that's great. David?
Yeah. I mean, it was a pretty spunky case from the diagnostic pictures. I thought, ooh, that looks pretty tricky because there's no certainty of getting it antegrated. There was absolutely no certainty you could get down the retrograde channel. So hats off to, attempt that. As it turns out, and it's a great example of how things change once you actually get good injection, proper opacification of the vessel, and they haven't even injected antegrade because of the damping. And now it does actually look really very different. It looks like a CTO that will be very ably completed by Margaret antegrade, quite possibly without any special interventions.
Nicholas, and while Nicholas is talking, if you can just show us the angio so we can see what they're doing. Nicholas?
I think what you also nicely see is the difference in quality of the diagnostic angio and the angios that you make as an operator, as an interventional cardiologist, an operator who is about to embark in a complex procedure. Oftentimes, the quality of the angios become much better. So I think really it changed the mindset up front. Just the fact that you have better angios.
So you'll see I got over enthusiastic there with a microcatheter. So I've sprung everything out, so we'll need to set up again, but we'll hopefully do that quite quickly.
So it's always good to see that people are human, Good to see that it's not only me that does that.
Oh, no, and also I was every single time one of the panel said that this will be, straightforward, easy integrate, I was biting my tongue.
No,
I didn't say that.
This is a pretty complex CTO. There's no question about it. But I just think it's just amazing watching this. And maybe Ajay and while Margaret is working, you can tell us about your first wire, your guide selection, all of that. It will really help the audience.
Yeah. So I think that the key thing is not to get. There's so many different choices out there, and you want to simplify, and you want to know your equipment. You want to know that well, which means you have to use it pretty frequently to know that. And so what we've decided in this case is you can debate side holes versus no side holes on the guide, but basically taking aggressive guide so that support's going to be less of an issue. We have as backup a trap liner. The rationale for that is that if you have to go ADR, and the probability is significantly high that you have to, you don't want to sort of have a microcatheter in, no guide extension, then you have to come out, and then the lumen starts getting pressurized, and then you can really have hematoma expansion distally in the subintimal space. So you start off with a trap liner, it's all 7 French, and a microcatheter du jour, in this case it's the Corsair Pro. We could use a Turnpike, you can use Mamba, whatever you want. And then the first wire we started with the safety wire was actually a Xi'an blue to get into the vessel. Then that was used to advance the microcatheter down. And once we had that, then you can start with a soft hydrophilic wire. And so we typically, Margaret and I both use Fielder XTA for that purpose. There are others who say, don't ever do that, just go straight with a Mongo or go straight with a Pilot. But I think the XTA is pretty reasonable, and you saw it made reasonable progress there. So that's basically what our setup was. As far as the access, we've gone by radial. The left radial is great for the Lima. You can see it engaged it much better than before. And then otherwise, the right radial for the right tends to go pretty well. So I think in this case, that's a pretty reasonable setup. And Roxana, you've done so much work on bleeding reduction and that kind of thing. The access is pretty important for that. So that's why we've done it in this way.
So what was happening there was the guide.
Yeah, go ahead, Margaret.
I was going to say the guide extension was kind of stiffening the guide. So I had to take all the kit out to allow me to manipulate the guide. I was trying to take a kind of shortcut and take the wire inside the guide, but sometimes when you've got so much kit in the guide just won't work quite as easily. So, and that's another example of when the fellows put the guides in for you and you haven't engaged the guide, you don't know where the ostium is. Another example of that type of scenario. Deborah's saying to me it's lower.
No, I mean, I think it's good.
No, this is all good learning because it's a lot of it's set up. You saw the guide when it was in was perfect, but it's precarious. So if what actually occurred in this case is you can, with the microcatheter going forward, it formed a little bit of a loop, and then that's how it bounced out. But this will go back in, and we'll then be able to start where we were. Key thing for teaching as well is we don't want to basically be injecting antegrade, because if you inject antegrade, you pressurize the lumen and you're in bad shape. So now we've gotten our damp pressure again, which we know is indicative that we're in. We don't have to give any dye. And just like Holger's case earlier, this one actually, the creatinine is a little bit elevated, so we brought the patient in earlier. We actually pre-hydrated him. We did an EDP to start the case so that we could use Sam Brar, who is our former fellow. Roxana, you worked very closely with him, just like me. His Poseidon protocol, it's a Lancet publication based upon the EDP. What you end up doing is changing your hydration strategy because we want to be cognizant of all those other risks of the CTO. And Roxana, maybe a question to you. It seems to me that the indication that 2B, a lot of it came because of the risks of CTO PCI. You want to talk a little bit about that and how operators should factor that in? Because this is a clearly indicated case, but that's something we don't talk enough about.
Yeah, I mean, I think this is, first of all, 2B means that you can consider it, and that's what you're doing, and you're considering it in this particular patient. The truth is that we've seen, and we've all seen, a lot of CTOs that are not quite as symptomatic as yours, quite as, approachable as perhaps this one, and in the hands of probably not all of the most skilled operators. And I think that the data is not as clear as and it's not definitive. I think we have one trial, but how it works, and I think we need to have more evidence, and I think we talked about that. So yeah, I mean, it's great to see that you're worried about the complications. So Margaret, tell us what you're doing now.
Yeah, so we've got back to where we were. So where the wire tip is now, I'm getting a little bit of resistance. So first thing we're going to do is come to the REO to make sure that we are indeed heading where we think we're going. So, you ready?
One second. I just want to make sure that retro's in.
This is an important point, just to make sure that we're heading in the right direction.
Yeah, if it just advanced that a little bit.
Yeah.
Perfect. Okay, good.
Okay, you ready?
Yeah. Inject retro. Go ahead.
Okay, so that's good. So we're not in the marginal, so we're in the architecture.
Yeah, it looks good.
Okay, so let's go back to the LAO. So what I'm going to do here is have another little feel here just with the XTA, and if that's struggling, I'm going to start working my way up through the wires, and my next choice is probably going to be a Gladius here, which will take me from 1 gram up to 3 grams of support.
Okay.
So
We'll watch
what
this
about
a little
guide
before we
extension?
go back to Erasmus. Go ahead.
Yeah. So what about a guide extension? I would typically have already a guide extension ready at the start. Do you have that too? Is there a guideline or a Guidezilla?
Yeah, so we had the trap liner, dual lumen catheter, and try to parallel wire from there.
So first thing I'll do, I think, is change the Gladius just for a different wire. So I'm going to change my wire, because I think the XT is trying, if it's not already subintimal, trying to go subintimal, so I'm just going to change the wires.
Mongo or regular Gladius?
So just a regular sign.
Yeah.
So which is your next wire now, just to keep track?
This is a Gladius wire, so it's polymer jacketed,
Okay.
so it should stay in the architecture of the vessel with a lower risk of exiting the vessel and causing perforation. And it gives me 3 grams of support, so 3 times what I had with the XTA. Another thing that's nice about it is if I was in a situation where I wanted to knuckle, it's a great wire for knuckling. I don't want to do that in this case, so because of that marginal branch. So if this doesn't cross, I'm going to go with the dual lumen and see if I can redirect, just like we discussed earlier on.
Yeah.
And again, the support issues of the proximal vessel are important to consider. So there's diffuse disease there. If with some progress we're having issue with the microcatheter, then what we'll do is we'll take the microcatheter out with a trap, dilate the proximal vessel 3.0, then get a trap liner into the proximal vessel with this thing, and then keep working. So that's our next step. I know you may have to go to the other room. So if you do that, that's probably what we're planning on doing next.
Yeah, so let's just see what this second wire does, and then we'll go to the other room.
Yeah. It's like it's extra flat.
Yeah, it certainly looks that way.
Can you just
see the way the
show us?
wires behave in there? So see that? That makes me think it's probably extra flat. So I'm just going to spend a couple of minutes seeing if I can redirect with the single lumen, and if that doesn't work, then what I'm going to do is go to the dual lumen. So what I'm going to do is just back up my microcatheter a little bit, see if I can find a different track more proximally.
And this is super important, microscopic movements, tiny, tiny adjustments, so that, and working carefully so as to not extend that big extra plaque space.
And I can see she's really redirecting it in a different direction, a little bit of a different direction as before. Yeah, I see it.
Obviously, the wire is going to always want to track where you were, but sometimes just with a different wire, you just get to pick up a different.
I think it looks a little different.
Yeah, I think so. Yeah. Other thing that sometimes can make this difficult is because there's disease downstream.
All right, well, you know what? We're going to let you keep working. We're going to go to Erasmus if it's okay. We want to see how they're doing. Sure. Let's go to Erasmus.
Yep, perfect.
No problem.
I wonder if we'll get...
Hello there. Tell us what you've been doing.
Yes, a lot of nice things.
Good.
Maybe we can show one thing. So basically, we advanced the microcatheter. We redirect the knuckle because it was going in a diagonal. We saw it. So we redirect. Do we have? Yes, we redirect. You can see here just in the LAD, and then we advance the microcatheter, and the microcatheter got stuck in the calcium. It is so calcified that the tip of the microcatheter totally crushed in the calcium, and it got blocked. Even the wire in the microcatheter got blocked. So basically, we had to remove the microcatheter and come back with another one and to redirect. So now we are there, and what we want to do is to have just a short attempt. If we can redirect with a high tip load wire, we already tried with the Hornet, but it was not going in the right direction. We are trying with the Gaia 3. We can redirect a bit and do again a knuckle. If the knuckle doesn't work, we go retrograde. What's your opinion?
Well, you know, I mean, I think it makes a lot of sense what you're doing. I was just wondering, were you able to even get anywhere to get any kind of imaging at all. It doesn't seem like it, right?
No, because it's so calcified that nothing was crossing there. You see, there is a
I could
really
see.
a chunk of
I
calcium.
see it.
We need
Yeah,
to
it's a
dissect.
rock. I mean, you're going to have to do. Yeah.
So we really need to
David, what do you
dissect this
think?
and bypass all this calcium.
I think it looks quite tricky at the moment. I'm not sure if the tip shape on the wire is enough to get around. It's quite an acute angle into the LAD, isn't it? And it's very heavily calcified. I mean, I wonder if the retrograde approach is worth considering sort of earlier rather than later, perhaps.
Yeah, I'm sort of in that
I think
direction.
we will have a low
Holger?
threshold to go to the retrograde.
Roberto, can you tell us what kind of wire are you currently using?
Gaia 3, just to
Gaia
make
3,
a dissection, and then I want to go with the knuckle, but it's really not going easy. So maybe we can try with a big knuckle. Yeah, it's going through the diagonal. It's very funny, huh? So we can try to make a big knuckle and bypass the diagonal. That will be also one idea.
You don't shape the Gaia wire, obviously.
Generally
so,
not.
Yeah, so it has a tendency to go straight and into that
you
diagonal.
You can put a shape on your Gaia, if, you know, because it seems like it's quite an acute bend into the LAD there.
Yeah. Let's
Sometimes
try
when I
again
see
with
that
the
much
Ornet
calcium-
14. It's really calcified.
Yeah, it just, it's
So
very,
we're not
very
showing easy
calcified. And you
cases,
wonder. No, and I'm wondering if you, instead of such a stiff wire, to think about like a whisper or some kind of a pilot just to kind of get through. I don't know. What do you think?
Well, I'm thinking the stiff wire not to go through, but just to get the dissection, and then to go through with the knuckle.
Yeah, so that was in my mind. I would maybe try with a Pilot 200 to try and get in the right direction, dissect there, and then exchange.
And then put your thing in.
Yeah.
We already did with the Pilot 200. We are upscaling with the Confianza. Sorry, with the Ornet 14. Sorry, even more than Confianza.
Oh, pokey.
That's out.
Yeah.
So then, if also this one doesn't work, we try retrograde. That's really a tricky.
So you came
case.
back a little bit with
Yeah.
your microcatheter.
Yes,
Just to
try
allow the wire to make that bend.
Yeah.
Yeah.
This is quite a tricky case, I must say.
Just quite a
Really
big
rough.
angle, isn't it? I wonder if another view like an LAO cranial may help you see what direction you should be heading in.
Yes, we tried the LAO-cranial, but for the very proximal LAD is not helping much. It's helping when you are already at the proximal part. So this
That looks
could be
better.
different. These look different, huh? We really had to push with the Ornet 14 through, huh? So we are a bit through. Maybe we can start trying with a knuckle. If we have not support enough, we can do a power knuckle. So we inflate the balloon aside and we give a lot of support to the knuckle. That's also an option.
And one other option is to do what you call a Carlino. And
Carlino,
to
yeah,
give a little bit
sure,
of contrast
right.
into that space and see if you can, you know, get some room there and have the subintimal space progress a little bit in order for you to advance the Corsair and the wire.
Yes, sure. That's a good point, yeah. Shall we try first the knuckle and then we can try the Carlino, of course, yes. Okay, the knuckle, the filter externe.
For how long do you usually
So where is your-
try to go for the integrated approach? For how many? Do you have a plan in advance for how many minutes you want to try it? before you go for a different strategy to go retrogradely?
Yeah, well, usually we don't give us a limit. Our limit is not to waste too much time doing the same thing. So 10 minutes is usually enough to change strategy. This doesn't mean that is per se retrograde instead of antegrade, but is a different strategy, which could be a different antegrade strategy also. So what we don't want to do is to stay there in failure mode for half an hour doing the same. That's for sure not what we want. So again, doing in the, okay.
One other option would be to occlude the diagonal branch using a balloon so that another knuckle cannot progress into to that one. But of course, that is a lot of material.
We could do with a dual lumen microcatheter, one in the diagonal and the other one puncturing the main vessel. But in that case, we cannot proceed with the microcatheter in the knuckle then. So it's a bit tricky also.
Yeah.
Yes.
I'm thinking that soon you'll be deciding if you're going to go retrograde. I mean, I would be.
That's correct.
I wouldn't just be careful because you don't want to cause the damage.
I think we're gonna have some feeling retrograde now because we have tried quite a lot. We will have a feeling retrograde. If we can go retrograde, then it's an important step.
Well, I mean, I think what you're showing us here, how difficult these are. You chose one of the most difficult CTOs. I would say yours is even more difficult than the guys in New York. So thanks for bringing us such a challenging case from Erasmus. But we're going to go back to New York. If we have time, we'll come back to you. I can't promise. But thank you so much.
Right.
I'm hoping that Nicholas will give us results tomorrow of how this all went, if that's okay, because we're so limited. But thank you. You guys are really showing us how meticulous you're working and what it takes to do CTO, a lot of persistence. Thank you so much. We're going to go to New York, and if we have time, we'll come back to you, we promise. Thank you. Let's go to New York.
Can you see us?
Yes.
Yeah, we see you guys.
Hey. So
can we get them full
Roxana,
screen, everybody? Yeah, great.
You're making it a competition of whose is harder than whose.
You get to watch me put on
Yeah.
So,
it's tough. It's tough over there. I don't know if you got to see it, Margaret. A very tough case.
Yeah, we did beforehand.
I didn't like it though.
So the story here is that, so interestingly, so we made progress and then stopped at that point. And what we ended up doing is trying to take a dual, but for whatever reason, this sometimes can happen during the case, the distal collaterals from the apex were less visible, so we can't really see our distal vessel. So again, exactly as was said in the prior case, you don't want to perseverate too long. So what we opted to do is to go with the second access point and took the lima out and go and engage with the EBU so that we'll have better visualization of the distal CTO. So once we do that, we can then try making our progress, but just doing it in a less haphazard way. If you don't have distal visualization, you don't have a case, or at least it'll end very quickly. So that's basically what we've opted to do at this point. And so this is an EBU coming from the left side. We'll get this engaged, and then we'll have better visualization to then go through our next steps. In terms of our algorithm, what we have at present is we still have a wire with a microcatheter. We will need to switch it for a guide extension with the trap, so we'll switch back for the trap liner. And then we were going to plan on using a dual lumen catheter that's over the wire to allow us to basically redirect our wire into where we think the correct plane is. Yeah. So this happens. One of the things that is useful is to switch to the back end of the wire. Obviously, don't extrude it from the guide, but at least this way, give the back.
Yeah, give me the back end of the wire, I think.
At least this way, you can readjust your guide up and down to basically get it to go the direction you want it to go into.
So as you was saying, the important thing is here we're not sure where the wire is in relation to that bifurcation. I don't want to track any further anteriorly until I know exactly where we are. So just stop, take time, change the guide, make sure we can see what we're dealing with. And also it then sets us up for the option of coming retrograde if we need to do that.
And I think some people would say at this point, like, why don't you just advance your knuckle, shove it down there, and do an ADR and all that, right? So the reason that we don't want to do that is twofold. One is because A, there's that marginal branch that's there, and we'd like to preserve that if we can. And B, we don't actually have good distal visualization to be able to know if our ADR is going to be successful. So that's why we're trying to get a good distal visualization by trying to get this guide into the left main.
Yeah, I think it's a really good strategy. Really good strategy to pause and change your left-sided guide. Also gives you a chance to test Margaret's lower back muscles.
Exactly. It's a short guide as well.
Yeah.
Yeah, for that reason, actually, for a lot of these left radials, we adapt snuff box because it gives you that extra inch or so. Just other things too is that we do have a setup here where we're using the Rampart system, so radiation protection as well. I'm a little bit further back, so I'm not wearing lead actually at this point because of the way the system works.
Yeah.
Oh, wow.
Wow, that's impressive.
No lead.
Yeah, so basically just the way it works is that there's shielding underneath, and there's also this big thing up here on my left, which corrects for the scatter. There's lead here, and there's also lead flaps that are right by Margaret's left hand.
Amazing.
And that basically allows you to reduce your radiation. We're going to be studying it actively. The Emory folks have studied it in our initial tests that we did prior to CTO Summit, which is when we got it. When I was wearing a real-time dosimetry badge at the end of a complex PCI case, I was up front. My exposure was, if I did 1,000 of those cases a year, it would be less than what's allowable, the 5 rem limit for the year. Now, admittedly, this is with this digital dosimetry. It's not the same dosimeters as analog dosimeters. There can be other scatter, but that's why we're going to study it more aggressively. What we definitely also found is if you're in the second position and down here, though, the radiation was almost minimal. And what's cool is it protects the whole body, not just where you're wearing lead.
So this is very frustrating.
Margaret just said this is pretty frustrating, and it is because the way the guide is situating. But that's okay.
So AJ, do you have therefore someone sort of looking after the patient, and does the patient have any sedation in this setting? Because you're quite separated.
We should probably change this guide if I can't get it.
Yeah. So the circulating nurse actually is wearing lead. Brian's wearing lead, and it will come around to the front and do it. What's cool actually about not just this system, but when you start thinking more about radiation, we actually have another shield set up there to reduce their radiation as well. I think it's just emblematic of when you think about radiation as a whole, which we don't often do, you then start doing other things that are important as well to limit the exposure as you've seen.
375, 90 cm.
So I'm trying a couple of things here. I'm trying to use the back end to see if I can get the guide to reach. And I'm also trying to just slightly free wire with the coronary wire when I get close, neither of which is working. So probably what I'm going to do is change to a 375 or from the left arm. So sometimes it's a bit like from the leg. And if that doesn't work, our other options are obviously to change to a femoral access, or alternatively switch the guides, which I don't really want to do at this point in the case when I've made quite a lot of progress down the vessel. This is one of the downsides, I suppose, with starting with a non-interventional guide at the start of the case, because it was a better guide for visualization, but obviously not a guide that's going to help us with our intervention.
The other thing that we sometimes do in these cases, the post-CABG ones in particular, where there are graphs involved, is we'll actually go tri-access. So it'll often be 2 femorals and a radial.
Yeah, so that's what I was kind of going to ask you. Yeah. And I just feel like this EBU is a little bit too big. Are you going to get, maybe just try a smaller one?
It's usually from the left arm in the post-bypass patients in a man of this size. Usually it's too small, but we'll go up one size, and if that doesn't work, we'll go down a size. It's not an exact science. So basically you take the coronary wire. But the main thing is to change, because what we're doing is not working.
Back end.
Okay, thanks, guys.
So let's just summarize for us, because we're getting to the end of our time. I'm sorry. I know these CTO cases, they could take the whole hour. But why don't we just summarize for us what exactly you're planning to do, Margaret?
Yeah.
Yeah, so what we're going to do is we're going to get a guide in the left system. We're going to be able to visualize where that wire is, which I think is extra plaque at the moment. And then what I'm going to do is I'm going to take the Corsair catheter out, and I'm going to use take the trap liner guide extension back in. I'm going to take the recross catheter down to where that wire is. I'm going to try and do wire redirection or parallel wiring initially. And if we can wire into either the distal vessel or the marginal branch, then we're good, and we'll secure it. And if we can't do that, then what I'm going to do is come down the septals and come retrograde and secure the vessel. So we've still got several options that we can try. So as you say, we'll probably be here for a while yet, Roxana.
And I think the other thing too is that, again,
I love this. Yeah.
It's being patient. It's going through step by step, and we can actually, save some pictures at the end, and potentially tomorrow at the start of the course or at some point we can actually display it from both rooms potentially.
Yeah,
because
that's what I asked for the Erasmus group, and I was just going to ask you.
Yeah.
Yeah. So I wanted to just let you know that we're going to come back to. Hopefully, you'll show us the final results, take films of it, and we really want to see it. I think it will be great to see how you're going to do this. I really, really want to thank our wonderful, esteemed faculty over the last 2 hours. Thank you so much. What a fantastic second day this has been. I want to thank Ajay Kurtane from New York Presbyterian, Holger Thiel from Leipzig Heart Center, David Heldick-Smith from Brighton and Sussex University in Brighton, Margaret McIntyre from New York Presbyterian, and Nicholas Van Meegen from Erasmus. And we're going to go to Nicholas, who's going to give us a wrap-up of the day. Thank you all. Thank you all so much.
And just like that, also day 2 of TIO is coming to an end. This was a day focusing on really complex PCI, and I think there was a common mantra here. Intravascular imaging is really or should become standard of care when you approach these complex PCI cases, and maybe it should also be the standard of care of PCI in general. That said, I think the live cases were spectacular. I think we saw super demonstrations of how to approach and modify calcium with rotablation. We also had a breakout session on orbital atherectomy that also shows you alternative techniques to deal with calcified lesions. And then our CTO session was just excellent. Excellent, I think, for CTO experts, but also for more general interventionalists who wanted to learn about the techniques, how to implement imaging and coronary physiology, also these updated, refined antegrade techniques that Margaret nicely demonstrated. And then I think the mindset of the CTO operator was very well illustrated by Holger in his last presentation. The live cases also showed that CTO cases can really change direction as they are proceeding. I think both cases in Erasmus and in New York really take some more time, and I hope we can show you the results tomorrow. So this also is something that we have to discuss tomorrow, the results of today. So that's why you probably also want to join us tomorrow for day 3. Day 3, that is the day where Dr. Valentin Fuster is coming to give a keynote lecture, and we will have much more discussion with this extremely skilled and qualified faculty to discuss what is really relevant in contemporary interventional cardiology. So thank you all. Thank you, the chairs of today, Ajay Kurtane and Roxana Moran. Thank you, the faculty. I would want to thank the audiovisual team here in London, in New York. And I obviously also want to thank you, the participants, who keep on following TIO 2022. With that, I wish you a happy evening, a good evening, and I want to see you tomorrow for TIO Day 3. Goodbye.